Hello, Section 3. Welcome to Week 7 Ankle Sprains Post-Operative Management Wrap-Up. I hope all of you are doing well. Week 7, we're getting very close now to the end. I know that it's been an intense 7 weeks, and I appreciate everyone's efforts. I'm looking forward to reading everyone's group projects coming up starting next week, but let's get to the wrap-up. I want to try to make this quick. I don't want this to go over 10 minutes, so I apologize for that, making it 13 last week. Week 7 presentation, some of the presentation review quickly. I'm not obviously going to go through all this information, but some of the key points in the Robertson article, or the Robertson presentation on post-op of ankles and feet: pain, loss of function, instability. When you have those three criteria, that's an indicator for surgery. I think it's really important that people recognize what is important, what levels of disability or lacking of function is when surgery is required, and what other things are just simply can be retrained. I don't know how many times I've had people come in with ankle injuries who are like, well, maybe I need surgery, and in reality all they really need is me. And so if we're looking for a guide, I think that's a great guide. And lastly, arthrodesis is appearing to be better than a basic joint replacement. They have not mastered the joint replacements like they have for knees and hips. The ankle still needs a lot of work. That is a last resort kind of an issue. Arthrodesis is still, at this point, a better way to go. In the presentation by Boyles on foot ankle imaging and differential diagnosis, I still it's very important that we continue to keep in the back of our heads the Ottawa ankle and foot rules, with the sensitivity being at 100% and the specificity being kind of in question, not so as great, somewhere between 40 and 70%. The sensitivity is really the key. If it's a negative, can we really count on it being negative so they're not playing or working out or walking on something that they shouldn't be? So again, keep the Ottawa ankle rules in the back of your mind. I am a big fan of the Log-Hansen classification. It makes sense. The 2-word descriptors are the best way, I think. Other things just get way too convoluted, in my opinion. So in the Tejan presentation, I drew a few more tidbits from that, just because I thought that was extremely relevant to what we do. Reoccurrent ankle injuries equals functional instability. Shouldn't happen. So if you have reoccurrent ankle sprains, usually that's related to a functional instability that we can get rid of. That's why I say it shouldn't happen, because they should be seeing us. Well, functionally mobilizing people is still better than immobilization for acute ankle sprains. We're seeing in the research that getting people moving is still the better way. I often equate that to back pain. Get them up, get them moving, move it, move on. Or another phrase, motion is lotion, still pertains even to these ankle people. Neuro-re-ed may improve outcomes and reduce risk of chronicity. Again, that gets back to the functional instability. Shouldn't be happening. We should be training these people. And then finally, ultrasound doesn't work to enhance recovery. I know that's kind of obvious, but I think that there are still people who are using ultrasound to decrease swelling and to help with pain control. And in reality, that's 10 minutes between setup and take down and wipe up and clean up, that you could be doing something that's a little bit more functional. Put the ultrasound card away. Lastly, both thrust and non-thrust have been shown to be effective, and let's make sure that we're using both of those. And I think Tejan really spelled that out fairly clearly. So if we go into the literature this week, prevention by Osborne and Rizzo, ankle braces after 6 months. This was debated kind of in the discussion threads. There was lots of people use tape, kinesio tape, athletic tape, and there were some who said they use braces. But going out 6 months, that's a long time, and that was the recommendation. I equate a brace to like a big hug. It probably gives more proprioceptive feedback, makes them a little bit more aware, but it also probably gives people more sense of confidence. And perhaps it's great for prevention. I'm still not totally sold on that, although prevention programs have been shown, and the balance programs, much like ACL injuries, to reduce by 82%. I oftentimes, with my soccer and basketball teams that I coach, we do a lot of this kind of stuff. And most of the kids so far that I've been coaching are under the age of 12, so they're pretty much made of rubber bands and rarely get hurt. But as my children grow older, I think that the need for these kinds of things and the need for the kids that you interact with becomes even stronger. And the research supports that. The rehab of the hallux valgus, we'll delve a little bit more into this in the discussion threads. But gait training, exercise, and manual therapy have been proven to be effective. The Shoe article was I thought it was decent to kind of establish some precedents, because 56% of these people were not using their great toe for push off. Was it 6 months, up to a year after this surgery, and that's a problem, right? I mean, that really changes the gait. That really changes your gait and leads to other issues, I think, down the road. Mobilize, train, and strengthen. That's what we need to be thinking about. Mobilizing the foot, retraining the gait, strengthening the lower extremities. In the Cleveland article, Josh does another great job with this manual therapy and exercise. So while they turned out to be fairly similar as far as recovery, double the rate of reoccurrence at the home exercise program. That's not acceptable. Manual therapy exercise, once again, shows it's great for reducing pain and improving function, and in this case, reducing the rate of reoccurrence. Okay, so nobody talked, obviously, because the questions really weren't geared to this, but nobody talked about the preventing diabetic foot ulcer. I do think the Singh article is a really good article, and for those people who are working in a direct access setting, this is a must. And if you have, and diabetic patients are all around us, unfortunately, they are more, I don't know, at least in my practice, I see more of them sedentary, people who are diabetic because they are obese, they don't get the typical activity. And these are things that we should be inspecting, especially in a direct access. The filament, the Weinstein filaments, the ankle brachial index, or the ABI, is fairly easy to calculate. Has to be less than 0.9, comparing ankle and the brachial systolic pulse, and then visual inspection. These things need to be on our radars when we're working with diabetic patients and their lower half. So make sure that you, if nothing else, quickly make sure that you've got a good handle on the recommendations in the Singh article, and that article stays close by on your desk, because I do think it's important to be seeing those, or to be looking for that, I should say. Standout posts this week. So, I thought it was some really interesting discussion. A lot of people expressed some of their concern that they didn't see a lot of hallux valgus postoperatively, and that's fine. Certainly commenting on the literature and some of the strengths and weaknesses is then what you can do, and then you can certainly surmise or go find other literature. And I think everybody, I thought people did a good job with that. So this week, Alpha, Will, Christina, and Matt, they talk about the use of tape versus bracing and how long. There was a couple of other places where this was talked about. I thought these guys did as much as anyone, and using tape, one, is certainly an option. We know that tape, as far as its stability, only lasts about 20 minutes during an athletic competition, and then it's pretty much rendered useless. But are the proprioceptive effects still rendered useless? Maybe that could be argued. Bracing, they're recommending 6 months, and that just seems like a really long time for me. I have some similar views as some other people had expressed, that we should be training these patients and then without the braces on, and making them use their systems, and yet the reoccurrence can be high. So, if I'm an evidence-based practitioner and I'm looking at this, I got to be thinking about bracing. I don't see a ton of an athletic population that has ankle sprains. Certainly I see athletes, but this isn't a common complaint. So I have not had to make this decision, but based on the literature, you almost wonder if maybe we need to be leaning on those braces. Moving on, in Bravo, Josh, Pierre, and Holly discuss price versus early mobilization, perhaps changing opinions about where the emphasis should lie in rehab. Yeah, price is something that, or rice, depending on, what you've learned, rest and icing and elevation and compression, those things were still maybe heavily pushed early, and this early mobilization had probably has been avoided due to increasing swelling or pain or fear of making things worse, and perhaps we're doing a disservice, and we need to be more active and aggressive in our rehab process. And certainly you could still mix in the price thought process, but maybe it's not really as important as we thought it was. In the Charlie group, Matt and Jay discuss the importance of regional dependence with hallux valgus. They posted an article about patellofemoral pain and related to hallux valgus. There was another. I know this wasn't with Matt and Jay, but also somebody posted in regards to elderly people, and I think this was in the Delta group, and hallux valgus related to risks of falls. And I think that perhaps this goes this falls too many times by the wayside, and we aren't looking at this. And from a regional interdependence perspective, you obviously you can't go below, but you obviously can go up a couple and see perhaps of where else you can help out, and that maybe in this case the knee for patellofemoral pain. This could be an opportunity to make even greater change. A simple quick check. It wouldn't take more than 10 seconds to look at the great toe in your screen. Lastly, in the Delta group, Laura had some great insights on working with dancers and gymnasts with fear avoidance issues. I had posed the question to her as well as an article kind of looking at some of the fears related to gymnasts, related to and dancers related to feet. And I thought she did a really nice job of saying that this was an issue and that, and her the way in which she coaxes and encourages these folks to return. And I think you could use her thought process with any athlete or for that matter, anyone who has fear related to putting weight. I had a woman just last week who came in a wheelchair because she had landed hard on her heel, and I was a bit perplexed as to why she needed to be in a wheelchair just because she had fallen while dancing on her heel, and she said her heel was sore. And just through some kind of step-by-step process, much like what Laura described, she was able to, put weight on her heel, stand, walk, do the things that she needed to do, and then start to engage her foot on a greater level. But by taking away that fear, she was more comfortable, and that's a lot of what we do in a lot of cases. Okay. Week 8. So the last week, you guys. It's age-related lower extremity disorders and stress reactions. The group projects, they're due by noon on Monday. Don't delay. Get into your group projects. Make sure you've got everything lined up and ready to roll. You'll be responsible in your groups to respond in regards to the group projects. No feedback is required this week in regards to your original posts, just in the group projects. So post your original work, but at this point, or for this week, you won't need to interact with anyone. You certainly can if you want to, but you don't have to. But you will need to monitor your group projects and respond to questions in relationship to that. Peer grading, please. I think it says get them in by Wednesday, but if you get them to me by Friday, that would be fine as well. Just don't delay. I have 3 days of lecture at the University of Minnesota this week, so it's going to be a busy week for me, and I'm not going to get to them until Friday anyways, and I hope to have your grades. Hopefully I'll be able to get one more video cast out for the last week as a wrap-up and kind of summarize where we're at and everything. So if you have any questions, obviously shoot me an email as we get toward the end. But I've certainly enjoyed this week and enjoyed everyone's participation. Take good care to all. Have a good weekend, and we'll see you in 1 week for the final one. Bye-bye.